I'm delighted to be here. As said, I'm Cathy Bellman, and I'm recently in post as the local care lead. Delighted to be in post as the local care lead for Kent and Medway SDP, because I'm such a champion for integrated care, having just worked in the Encompass Vanguard, one of the NHS Vanguards in East Kent, where we have achieved integrated care, and it's made a difference not only for patients in the quality of care, but actually for the staff. So it's heartening to know that it does work and we can make it work. And so that's what I'm going to do. That's my role, if you like, to champion that for the next however long. I think David said most of what local care is. They're doing a lot of work in West Kent, which is absolutely fantastic. And of course, if some of you have been around as long as I have in the NHS or other services, you'll probably stand there and say, well, we used to have integrated teams years ago. This is nothing new, and it is nothing new. But I suppose as organisations got bigger and the way we were all commissioned, it put up some barriers between us. So we stopped sharing and we stopped talking to one another. And that's actually what we're trying to do now. So thankfully, we have a collective agreement across the whole of the SDP footprint for all those senior leaders to really drive local care. And that's a real drive to work together, work collaboratively to provide better services for the population. So where did we start in the SDP with understanding what we had to do and where we were going to start with local care? Well, there was a lot of work done around population profiling to understand what the population actually looks like. And you'll see from the sort of pyramid of needs behind me that roughly 6% of our population, those really vulnerable and mainly elderly and frail, were using about 80% of the spend in A&E. And some of that was inappropriately going there for interventions where they would have been better seen in a community setting at an earlier stage, or had some form of anticipatory care planning with an integrated team wrapped around them to stop them deteriorating in the first place. So it really is a bit of a no-brainer. Where were we going to start with the local care model, if you like? So we are looking predominantly in the first stage of the rollout at that sort of top of the pyramid, that cohort of frail and elderly. Now, that doesn't mean that is where local care is going to stay. We are going to eventually tackle the whole population. And you can see at the bottom there, the 78% of us that are relatively fit and healthy and don't use the services that much. But how can we support in time with the prevention agenda so that we don't get to the top of the pyramid? So that's the rationale for starting where we're starting. And some of the facts and figures, we know that any one time we have 30% of people in our acute hospital beds that are in fact ready to go home, but we haven't got the pathways. As David said, we're not talking to one another properly. So, there aren't the people talking to one another to get those people back into their own home settings. Also, people are arriving at A&E, and if you look at from a mental health perspective, a lot of those frail and elderly do have dementia or other mental health problems, and the worst place in the world for them is to be stuck in an A&E corridor on a bed, confused, frightened, where they should actually be treated at home with a team that's actually caring for them properly and a better quality of care. So I'm going to nip through a few of these because I think we've said some of it. But that bottom right-hand bubble there is actually where we hope to get to. So about 155,000 people are in that sort of top of the triangle. And if we could tackle those by working together and creating a team around that cohort of patients, potentially we could have the impact of easing the pressure on A&E by 35%. So, that's not an insignificant amount to support our acute trusts, but it takes us collectively, all of us, to a collective sort of push from us all to do that. Now, David talked about the integrated team or the multidisciplinary team or the MDT. And actually, the one thing I am going to do in my role is actually get us all talking the same language if it kills me. Because we talk about hubs, we talk about CHOCs, we talk about primary care homes, we talk about MDTs. We are confused internally as organisations. So how are we going to tell the general public what local care looks like if we can't articulate it in a simple fashion ourselves? So if it kills me, we're all going to, I'm not fussed about what language we use, but I think we have to have adult conversations about what we're going to call things so that we can describe it to the public. But this is an MDT. And very typically, that's everyone coming together. Now, I think the biggest difference is it's not just the statutory organisations here that we're talking about. It's not just the local community trust, the mental health trust, the acute trust, etc. We are looking at the input from the voluntary and care sector. And where I've come from in East Kent, we worked very closely, and I could see some of my colleagues from Red Zebra there, around social prescribing. And the impact of that was phenomenal. About 26% of our referrals were for social isolation, and we've heard the impact of being lonely on your health. So, we've got to get other partners to come around the table to talk to us. And part of that is getting over the information governance, the data sharing, and all those other sort of governance frameworks that stop us talking to one another. So, but that's not insurmountable. We can get over those. What I would stress is whatever we're doing as teams, the person in the middle is the driver of their care. So nothing starts off without talking to that individual in the centre of the slide there, and they're sitting with their partner, so it's more than just their own care, it's the other determinants of their health, and they may be caring for someone else. But actually, what is it that matters to them? And I think sometimes, I'm from a health background, we over-medicalise things and we decide what people need. And actually, that might not be their goal at all, as we found with some of the work we've been doing. So it's understanding what their goals are, what their needs are, and then getting their consent, and that's informed consent. So there's something there about informing people that we are all talking to one another. Out of the few thousand people we put through the Vanguard programme, interestingly enough, not one person refused to have their data shared with other colleagues. And the common theme there was, don't you already do that? So that's something to be said about the way our organisations work. But actually, it's then about getting all those people in the room, getting rid of the hierarchy, because the person, the social prescriber has just as much an influence on that care plan as the doctor would have, or the geriatrician. So it's really important that team comes together, and that's a change in culture, getting rid of all that hierarchy, and that's so that's something as well. Interestingly enough, the work we were doing in East Kent showed that there are loads of other people that we can play with and come around the table. We didn't realise that the police do quite in-depth planning and care planning around certain cohorts of the population. We don't talk to them in health. I don't know about other agencies, but and it's about getting really smart with the way the MDTs are run. So we had one particular practice, which was the university medical practice. Now, they're not frail and elderly, and they have a very low population of frail elderly patients, so their focus is mainly young people. But a lot of young people with mental health problems or social isolation, even though you're in a big university. So we started running some specific MDTs around using the younger adults consultant, mental health consultant, and tailoring the MDTs so that we were talking about the right cohort of patients, because you don't want all those expensive clinicians or otherwise sitting around a table when half of the discussion has nothing to do with them. So it's about getting smart in the way that you run them. So, and I'm going to make a plug here, because we're running a conference here on the 18th of April for MDT. So we want to get although there'll be local nuances, there are some sort of top tips for running MDTs and some things that the principles, design principles about what works, what doesn't work. And we're running a conference to share all the good work that's going on across Kent and Medway, because there are pockets of fantastic work and we've got to talk to. So anyone can contact me about attending that, because the more the merrier. We want to get everyone. And they're really operationally focused, operational staff there. Now, I don't know about the technology of getting Valerie. Are you all right with that? So don't listen to me. This is Valerie. She's now 93. Valerie looks after her husband, who has dementia, interestingly enough. We put her on the programme when she through an MDT process when she was 92, and she hasn't been admitted back into hospital since. But don't listen to me. Let's hear it from the person that's really at the centre of the care. So this is Valerie. We know that health and social care is under tremendous pressure at the moment, so we have to do things differently. And so coming together as a vanguard has sort of allowed us to fast forward those changes to make improvements.
The whole side of caring for patients has got a lot more complicated, both medically and socially, with lots of different teams going in and not really all working together.
I got very muddled at first when all the various carers and voluntary workers all sort of turned up. I came out of the hospital and I felt very, very low indeed. And if it hadn't been for Tasmin, I wouldn't have picked up like this or anything.
We want to keep people well in their own home for as long as they possibly can be. So if we can come together and identify the gaps in the care, we can actually start anticipating the things that might go wrong that would otherwise mean if they went into crisis, they would go into hospital, and that's the worst place for some of these people. Encompass is a partnership of 13 GP medical practices across Ash, Canterbury, Faversham, Sandwich and Whitstable, and they've come together to form something called a multi-specialty community provider, or an MCP. Now what they'd like to do is work together to improve the services for their local population. A CHOC is a community hub operating centre, and that's where we bring all that information together. So some of it is a physical thing where you bring teams together, and some of it is the use of the IT, the information that we need to share between organisations.
So the integrated care management is where we as a group of professionals all sit and meet and discuss our complex patients.
We're learning about what the other services can provide. You know, my role's always been to contact these other services, but actually to work so closely with them now as well. They give you, they'll say things, oh, this can be done for that person that you never knew about.
Being part of this meeting allows you to say, I can do this part, but I need some support from another element of that. That could be via the voluntary sector, going in and supporting, looking at loneliness of patients. And you might have recognised it, but you might have been able to be in a position to provide the support that needed.
We have a better access to our health colleagues, and they have faces to put to names, and social services isn't some kind of shapeless entity in the background. It becomes a real thing.
A lot of the existing services are integrated together, and we're in there right from the start. So we are an additional route, additional prescription route, if you like, for health workers to help to address those non-medical needs.
We do a lot of joint working with care agencies in the community to promote good practice of mobility, transfers, manual handling, looking at maybe bespoke equipment that might not be the norm.
Everybody has come to the house, and willingly, and I've been very, very grateful for that.
It's important that the patient is at the centre of the care plan, because it is about the patient. A patient who is unhappy with what you put in or provide won't use it. And the things that seem important to me actually may not be the most important thing to the patient. I would never have thought for Valerie that a trolley with a carrying area on it was going to transform her life.
When I am on my own, I do use it. I push things around. I files if I'm doing something, or books if I want to check books.
We see this as a model for dealing with the whole population and feel really positive that the only way forward to improve care for people in our local communities is to have a truly integrated services that are working to use resources more wisely, but actually increase the quality of care for that growing population and the needs that are out there. So it's not about one particular area, because we're all trying to do this. So the role now in the SDP is actually to help people with developing multidisciplinary teams, and I think the West Kent's well on its way. But across Kent and Medway, we're all at slightly different stages, but we need to move forward together and collectively. Thank you.
Thank you, David and Cathy. Now, do we have some Slido questions? We do. Here they come. So, districts can offer lots of resources: well-being, housing, adaptations, prevention. Do you think districts will ever be truly part of local care? Who'd like to deal with that?
Absolutely, yes. Discussions have been going on, certainly from the Commissioner's point of view, with districts for, at least 3 years to my memory, and there are actively regular meetings going on with the district teams, district councils. They are essential, and they provide essential information, essential services, and support, and they're integral to the development. So, yes, they're fully on board and should be.
So when you say everybody needs to be involved, you mean everybody?
Yes.
Yeah, okay. Is there another question? Is there a case study available as a result of the East Kent work that can be shared with the whole STP? That's a yes or no, I suppose.
Yeah, as you can... Is it working?
It's
yeah.
working.
As you can imagine, as a Vanguard site, we were heavily monitored by NHS England, so we had to produce an awful lot of data, which was scrutinised, and a lot of that was patient stories, etc. We've also had the University of Kent to sort of validate the data and do some studying around sort of that qualitative experience, if you like, for staff and patients and carers. So that will be available in April, and that can be shared.
Excellent. We'll let people know how to do that in the follow-up packs. Have we got another one? Where is the evidence being collated to prove the improved outcomes from the local care changes?
Shall I take that again? I mean, we do know where the... in East Kent, the population is about 170,000 on the Vanguard site, and that data was validated. That our sort of admissions avoidance was minus 6.8% in that area. Of course, the local hospital doesn't recognise that because it's not a big enough scale. You need to be doing it on either an East Kent footprint, or you need to be doing it on a Kent and Medway footprint. So whilst you can make an impact with one area doing truly multidisciplinary team working, we're not doing it on a big enough scale to help our colleagues in the acute trusts. And I say help, I mean support.
The other thing I think to answer that question is we need to answer it in a broader sense. So local care, as far as I'm concerned, needs to include, from a mental health perspective, the home treatment teams, the urgent care, how we deal with crisis, how we make sure there's an earlier intervention in health deterioration. So all of these things need to be done within the local care environment. So the urgent care treatment centres that are being set up are are aiming to reduce casualty attendances, to signpost people properly, to get support workers engaged. So local care it's even more than the MDTs that we're setting up or that we have set up. It's beyond that. And in mental health, it is so important that we have more resource and more staff within the local care environment to do these things, which we can do synergistically in adult healthcare with KMPT, and I believe we can do it quite quickly.
Thank you. I think we have another one. How do we move funding around the system to allow a new local care model?
I don't know.
Well, we're doing a little bit of work. So we have a local care implementation board, which Paul Carter chairs, and Alan Jarrett is the vice chair. Now we have all the chief executives from all the provider trusts, and we also have people sitting around there from the LMC and whatever. It's a rather large board, so we have representation from people like Health Watch and that, so we haven't missed out the patient's voice. So they have collectively agreed that local care is their priority. The first meeting was on the 8th of February, and that was a collective agreement from everyone sitting around the table that they were going to make local care work. Now, we have a workshop next week to actually then start looking at how do we release the funds to make local care work, because there's money has to be moved within the system, and we have to move it collectively to support that change. So that will be the focus of the workshop. Oh, yeah.
I think the key thing about the question is that we shouldn't identify local care as an isolated part of the system, which is why I talked about pathways. It is so important that if we create an effective, efficient pathway, the system likely is it prevents health deterioration, it frees up money to be reinvested in the right bit of the system, and we need to get away from the sense of ownership of an employee or ownership of part of the system. So in a sense, it's not about really, I've begun to move away from we need to shift money from this bit to this bit. It's about sharing the responsibility of the whole pathway, and everyone saying, yep, we're in it from where the patient starts to where the patient goes and back again. And that way, actually, that question should disappear.
Excellent. I think we have one more. Does the CQC, the Care Quality Commission, fit into any of your conversations, or are you consulted in any way?
Yeah, so we've been working with Fiona Morris, who's the South locality, our connection anyway with the CQC, to understand a few things, because it's a changing environment for the CQC as well. They want to know how they're going to inspect these new models of care moving forward. So one aspect of that is looking at GP practices as they come together. How do they inspect GPs at scale? Because at the moment they're all inspected singularly. And then as we start to morph into another organisational form, how they're going to inspect that. So we're working quite closely to help them develop the model of inspection, because it's changing for them as well.
Okay, thank you. I'm conscious that lunch is looming, so we'll have one more question, I believe, and then we'll break. Will our local care vision help us develop and deliver a single joined-up dementia strategy for Kent and Medway? If so, by when?
Okay, yes. The answer is yes, it should. I can really only answer this from a West Kent perspective at the moment. And that is that we have had over the last 18 months a very strong move towards providing a lot more early diagnostic facility and early care within local care. So the strategy has been to try to use the resource of specialist teams more sparingly, and in identify cases where it's really required. And this has worked really well. We've had a huge amount of support from the older adult teams at KMPT to set this up. And local care has got a number of pilot sites in West Kent which are delivering this. So if a patient is suspected to have a problem with dementia, There are now facilities and ways to try and identify, if it's necessary, which sort of dementia they have, what care they need, their carers need, the support that's required, all within the local care environment. So I do believe that is actually being done now, and we have a lot of support from KMPT to do that.